Hi guys, my name is Raisha Nurani. I'm a GPST3 in London, and today I'm going to talk to you about genetics in the CSA. I have been trying to record this video all week and there's just been one thing that's led to another, so I apologise for the delay. But essentially, genetics now, I'm quite lucky in that I quite enjoy genetics. I think it's an interesting topic and it's something that I have a natural affinity towards. But most of the time when you hear the word genetics, everyone gets really panicked and worried. And actually, if you look at the marks of CSA exams, it tends to be the genetics ones that have a lower pass mark. And I think people overall freak out and don't know how to approach it, and then they just don't do as well in genetic stations. But actually, out of all the stations, it's probably one of the most easiest CSA station to do, in the sense that it's got a lower pass mark, but also that it's quite organic. So it is not a station where you need to remember, oh, I need to ask about these red flags, or I need to check about this, or have I, gone through my 2-week rules, all of those types of things. And a lot of it is about letting the patient talk. So what am I going to talk to you about today? I'm going to talk about how to take the history in a genetic station and give you maybe a bit of structure so that you feel that there is something that you can hang your thoughts on when you're trying to take that history. We're going to talk a bit about how you explain genetics to a patient, and that is actually all you need to know for genetics. So if you try and look at it with a positive mindset of, this is actually not a very heavy station, you might find that you respond better to the actual genetics cases should you see one in the CSA. Okay, so when it comes to taking a history for a genetic station, the way I look at it is it's very much about, I kind of use that, the first fit pro forma, so very much before, during and after kind of mentality of when we start talking about genetics. So I might say things like, okay, so patient comes in, they tell you that, oh, my sister's son has this condition, I'm really worried about it. And you just go right back to the beginning. So you go to things like, okay, so tell me, how did this come about? And you kind of do a bit of a before history. How did this come about? Okay, and what's made you a bit worried about it? And they might talk about how they're thinking about getting pregnant, and they're worried about the unborn child. And then you talk about during. So you talk about how the family is coping, the child's coping, what they're already doing so far. So you might say, do they go to hospital a lot? Are they under a team? How's your sister managing? That's a lot of news. How are you managing? So you're kind of covering all the things that are happening during this episode. And then you start talking about after. And in after, you're very much talking about, well, what does this mean for you for the future? So you mentioned, when we were talking about things before, that you were considering having a child. What are the implications for you? Is that put you off? What would happen if you did get pregnant? How would you respond to that situation? Would you be interested in testing? Would you think about terminating? Obviously, use silences, because these are very big ethical life-changing situations you're talking about. But if you use that kind of format, you've kind of gently guided that patient along everything that's been going on, and you've kind of got a clue of where this patient is at this point. I would ask about ICE. So you said you're worried about this condition. I can see that you think this condition will be lifelong, and that's something that worries you. Is that right? What were you hoping that we'd do today? Or I know that you mentioned that there were blood tests. Is that what you were thinking, that you wanted some blood tests to check if you've got the condition? That kind of thing. So you've got a nice ICE there. Right, so that's all your history and ICE in a nutshell. And as you can see, it's a lot of time for the patient to talk, which is what should be happening in a true consultation anyway. The patient's given allowed an opportunity to really express their worries and concerns. So actually, history is not too heavy when you look at it in that way. And then let's move to management. So at this point, you've got an idea. You kind of know about the condition, or what the patient knows about the condition, and you've got an idea of where this might be going. So I tend to have a nice opening statement, something like, yeah, you're right, this is a genetic condition, do you know what genetics are? And patient will go, no, or kind of, and then you just use really simple terminology. So you may say something like, everything in the body is coded, from the colour of your skin to the colour of your eyes, and actually things like illnesses and diseases are also coded and then get passed down through the generations. Now what you have described is, and then you talk about the actual genetics of it. Now there are 4 real possibilities, I think, that tend to come up as CSA exams. You've got your autosomal dominant, your autosomal recessive, your X-linked recessive, just because there's not that many X-linked dominant out there and they're not that common, so it would be a bit of an unusual one to throw in. And then you've got something that might not be genetic at all, so that's something just to bear in mind. So I kind of think you need to, so this is where the bookwork comes in. You kind of need to go through your conditions and try and work out what they are, because you don't often have a lot of time in a CSA to go, right, I need to, I don't know if this is dominant, and I'm going to start drawing family trees and try and work it out, and I think you then just get lost in a muddle. So the easiest way, and the way I would do it, is right, okay, this and this condition are autosomal dominant, and then as soon as that condition presents in the CSA exam, you kind of go back to your grey matter and you go, right, this is an autosomal dominant condition, so let's talk about it like that. So once you've categorized most things, and think about things that are common, because hopefully that is what you should see in a CSA case. So autosomal dominant. So these are things like polycystic kidney disease, Huntington's, neurofibromatosis, and essentially all you really need to say about this is that, okay, so this is a condition where if you were to have a child, there is a 50% chance. So that means 1 in 2 chance of that child also having this condition. And if you want to throw in, this is described as an autosomal dominant, but I wouldn't even bother, because actually you don't need it. You've already explained to the examiner, this is an autosomal dominant condition. And what I try and do is, when it comes to probability, I try and give it in 2 ways. So you've done 50%, 1 in 2. Autosomal recessive, very similar. So the conditions that you have are sickle cell disease, cystic fibrosis, that sort of thing. And all you're then saying is, there is a 1 in 4 chance, so a 25% chance that your child will have the condition. Sometimes you can have the condition, but you can carry the condition, but you don't necessarily have it, and the chance of that is 1 in 2, so 50%. And that is sometimes referred to as something called autosomal recessive, in the way that it is inherited. There you go. X-linked is slightly more complicated, so have those words, have that spiel in your head, and these are things like Duchenne muscular dystrophy, haemophilia, and essentially what you're saying is, okay, so this condition can only affect boys. If you were to have a boy, there is a 1 in 2, a 50% chance that that boy will have the condition. Girls can carry the genes for it, the codes for it, but they don't ever present with the actual disease itself. And if you were to have a girl, there is a 1 in 2 chance that she could be a carrier of this condition, a 50% chance. This is sometimes called an X-linked recessive condition. And there you go, you've got your lovely spiel. So the real bookwork is working out what condition fits what pattern of inheritance, and working out the spiel for that particular inheritance mode. And that is all you really need to know for genetics. Now, don't be thrown. Sometimes you might get things like Turner's or Downs, and these are, the chromosomal problems, but they're not necessarily genetically inherited in the same way these ones are. So I think that is an important thing, and you might want to say, well, actually this isn't inherited. Sometimes the code that makes us, like I said, our hair or our eyes, can be mixed up, and you can get a disease. Doesn't mean that will be passed along the generations. And this is what has happened in Turner's, or this is what happened in Downs, and then you can talk a bit about that. Now, what happens if you don't recognise the disease and what pattern it fits? Okay, ultimately that is a difficult situation to be in, but think about all the legwork you did over in history and ICE, and actually work with that. So it is, you won't get the top marks if you don't know what it is, and you need to go, okay, well, I need to consult and find out how this is inherited, and I can tell you about this. But what you will be able to do is do all that legwork on history, understand what the implications, where this goes, and then you make a plan as you would, going, we need to work out more about the inheritance. I'm going to speak to my colleagues, or actually I think we might refer you to genetics if that is appropriate, and it sounds as though it's appropriate. You kind of need to make that judgment call. Once you've explained the condition, you're then going to talk a bit about the condition. You don't need to know huge amounts. Go, if this is sickle cell, this is what it means, and there's a lot of ways that we can test for this. And then what you're going to end is, actually, I can understand that you're interested in finding out. We will A, send you to genetics, B, actually we don't send you to genetics, but we will do some blood tests closer to the time, or if you were to become pregnant, then you would be referred for some screening for things like Down syndrome or amniocentesis. Just play it by ear. Most of the time, once you've done all your history taking and you talked a little bit about the condition and where you're going to go from next, so let's watch and wait and see what happens. Let's refer you to genetics, because we need to know if you've also got this condition. Then that's when you would really finish off and then say, look, we've had a lot of unanswered questions today, come back and see me. So you do a standard management, follow-up, safety net, and then that's it. So hopefully it doesn't sound as terrifying to you, but let me know if there's anything else you want to add. So when I started this, I had this kind of image of what I would do for each of the different videos. I've now come to the end of that, so I am I've quite enjoyed making them, so I'm happy to do a few on what you would like. So if you have any suggestions or comments, please put them below, and please subscribe, because it means that more people can see this, and it actually kind of serves its purpose, which is to help people on the CSA, and so it goes up on the news feeds, and tell your friends and your colleagues about it. Hopefully they find it helpful too. So until next time, you let me know. I wish you the very best of luck revising.